Live again.
You have it.
Oh,
Which one?
Live.
Right there. Yeah.
yes.
Are we live? Apologies for the interruption.
Please.
Keep going? Keep going. Okay. So I hope that I think it's a reiteration of what Chair Foster said yesterday, but I wanted to emphasize that hospital system transformation is going to be critical to address the following. Right now, we have hospitals and other providers' financial health that's poor and continuing to deteriorate. Our reliance on commercial prices to sustain the system is no longer a viable strategy. Given the affordability crisis we're already facing and the fact that we have a shrinking commercial population, this is not a viable strategy any longer. And despite the high expenditures on healthcare, many Vermonters lack access to care. And by some measures, we're seeing hospital quality declining. So hospital system transformation is critical to addressing this dual affordability and sustainability crises. If we can find system-wide efficiencies and lower costs, we will be able to reduce the affordability crisis. We'll be able to free up resources. If we have lower costs, we can free up resources to be able to lower prices. We'll be able to reverse the deterioration of access and quality. The Act 167 community engagement process was just the very first stage. It was the hardest work, frankly, is going to come. I'm going to turn it over to my colleague Hillary to talk a little bit about that community engagement process, and we'll dive into some of the results and sort of next steps.
Great. So next slide, please. Wonderful. Thank you, Member Holmes. I wanted to just start by introducing the Oliver Wyman principles that led the community engagement effort. Wait, see them up there. Many of you may have seen or talked with either Dr. Bruce Hammery or Elizabeth Sutherland over the past year and a half. So Dr. Bruce Hammery is a partner and chief medical officer for Oliver Wyman's healthcare and life sciences practice. He is a nationally known expert on the topic of redesigning health delivery systems. And prior to joining Oliver Wyman, he was executive vice president and chief medical officer at Geisinger, a very well-respected and large healthcare system in Pennsylvania. And some of you also may know Dr. Hammery from other Vermont initiatives. He worked with the Department for Financial Regulation, DFR, in the state's COVID forecast during the pandemic. So he's an infectious disease doctor by training. And he was also heavily involved in the wait times study in 2022 that was run by the Agency of Human Services. Elizabeth Sutherland is a managing director at Oliver Wyman, and she consults on a range of topics, really including health equity, strategic transformation, and organizational performance improvement. So some of her recent work includes identifying health equity zones in Pennsylvania and supporting the state in overcoming some of those barriers. So additionally, not mentioned on this slide, we did contract with Mathematica to support the data analytics that were needed for the project. So next slide. So this slide has a lot of text, but we wanted to provide you with a high-level overview of the engagement process. And we'll sort of walk you through all of the steps here and how we really worked to maximize engagement and the feedback that we were receiving from state and community partners. So we began this work back in August of 2023 with a series of meetings with stakeholders from across the state. And we really used this time to introduce the project and get their feedback on the engagement plan. So this was the plan that we were going to use for the work ahead. And it was really critical to the process that we had input into the approach early on, and that we had a wonderful group that was advising us and sharing different key contacts that we should connect with throughout the project. So as you can see on this slide, during the sort of plan development stage, we were getting feedback from leaders of health-related organizations. So we had folks from Vermont Care Partners, BUZZ, the Green Mountain Care Board's Primary Care Advisory Group, Health First, Bi-State, just to name a few. And we also connected with the Office of the Healthcare Advocate. I want to thank them for all of their work and partnership throughout the process. Many leads throughout the Agency of Human Services, the Office of Racial Equity, certainly leaders in the business community, many members of the legislature. I recognize you from some community meetings, and many others. So after the plan was finalized, we, in the second step there, set out on a listening tour. So this is where we held 2 virtual public community meetings in each of the 14 hospital service areas. So we decided to hold 2 in each community so that we offered an opportunity for providers to share their experiences delivering care. And then we had a second meeting that was really focused on hearing from the community and their experiences trying to find, access, and receive care. We also held some statewide meetings for folks that were maybe not able to participate in their community-specific meeting as well. We also held a special public comment period to receive written feedback from the community. And in this stage of the project, we had heard from over 1,000 participants. Great engagement. A full list of those that we had outreach to in this first phase was actually submitted to the legislature back in 2023 for the Health Care Reform Oversight Committee. So that is available, and we can get that to you if you're interested. It's also just worth noting that all of the materials for each of these phases of work actually still is up on the Green Mountain Care Board's website. You can sort of scroll past all of the information about community-specific meetings, and there's a catalog of all of the work that was completed, which is a great resource. So after that listening tour over the winter, Dr. Hammery also personally visited each hospital in Vermont. He wanted to get a sense of the geography, tour the facilities, and really during this time, he held many, I can't even underscore many enough times, meetings with individuals and small groups, folks that were really wanting to share their experiences and provide some additional information and insights into the project. This was also a heavy time for the data analytics portion of the work to be completed. So after the sort of winter, the data and draft recommendations were then brought to hospital leaders for discussion and refinement. And after that step, so hopefully you're seeing that we really worked to have a very iterative process. We then last summer embarked on the second major phase of community engagement. We held in-person public meetings, again, in each of the 14 hospital service areas. We sought out community spaces, so libraries, schools, town meeting spaces, and sent out invitations to thousands of community members. We had many partners that were involved in spreading the word and really engaging their communities to come out and join the conversation. The turnout, as you'll see in the next slide, was tremendous. So people were and really continue to be eager to discuss the challenges and realities of the local healthcare system, as well as ongoing initiatives that are being implemented to support care and think about what the future of healthcare might look like. So we are grateful to the hospital leaders, the community partners, legislators, and the agency leads who really helped promote the meetings and encouraged community members to join. So the next slide, oops, Kristen, you've got it up already. Thank you. So this is just a breakdown of our engagement numbers here. So we connected with over 3,000 people throughout the process. Meeting attendance for those second phase meetings out in the community ranged from about 30 people to almost 130. And we averaged around 68 people. Folks were engaged. We received 120 written public comments that also informed the work. And Oliver Wyman pulled a handful of quotes that illustrate some of what was heard in the meetings, which I'll show on the next slide. But as I said earlier, if you want to dive more deeply into these community meetings, recordings of them are still living on our website. And we are really, really thankful to the public access TV stations and our closed captioners who worked to really expand access to the meeting and transcribe and record and rerun these meetings for folks to participate that, if they couldn't attend in person on the night of. So the next slide, yeah, Kristen, you got it. Thank you. Just wanted to read a few of these quotes aloud. So this is a slide pulled from the Oliver Wyman final report. Was shared with communities across the state. Many individuals don't go to care because the premiums and out-of-pockets are too high. Keeping staff is a function of addressing the cost of living, inflation, the ability to find affordable housing. All of these have been difficult. And I can no longer afford the procedures or medications. The only option is to not take my medication. And, it's important to highlight that while there are some challenges here, we also really heard of some incredible bright spots from communities and the innovation that is taking place. And so that is also documented in the final report. So I'll turn it back over to Member Holmes here to discuss some of the key findings.
Happy to do so, but actually I want to take this minute to just recognize Hillary on this because she did Herculean effort to get out to all these communities. And she, logistics and the coordination and finding meeting places and working with all of these communities to make sure that the voices were heard and people were seen. And she did it like 8 months pregnant. And so, so truly Herculean.
But she couldn't control the thunderstorms.
And there was, and even in St. Albans went up there, very dangerous rainstorm, very pregnant. And anyway, so that is the dedication.
Grateful to my baby. He held off until the community meetings were done.
Okay, are we on the next slide? We are on this slide. Okay, so this is a sad slide. So this is the OW's Oliver Wyman's analytics team started with looking at a forecast of hospital margins, assuming a continuation of simply the status quo, the current revenue and expense growth trajectories. It's a messy graph. All the hospitals are here basically on this graph, though they're not labeled, that would be too messy. But the message on this slide is clear. Basically all but one hospital, if things continue as they are, will be in the red, some deeply by 2028. So without a substantial increase in hospital prices, insurance premiums and/or taxpayer-funded bailouts, we will see service line disruptions and hospital closures. Market forces will take over, and the simple but unpleasant truth here is that 650,000 people cannot continue to support the 14 hospitals that are offering the current portfolio of services. The same forces that are creating an education funding crisis that I know you're working very hard to overcome are also creating a healthcare funding crisis. It's the same problems, it's the same demographic challenges, and it is a similar need for urgent and substantial transformation. In fact, if we address the healthcare crisis, we will help mitigate the educational funding. This 144-page Oliver Wyman report is long. It makes many, many recommendations, and I encourage everybody to read it if you haven't already. This is an executive summary slide, but at a very high level, the report urges 3 imperatives for Vermont's healthcare transformation: building housing so we can attract a workforce, invest in EMS and other transportation so that patients can access safely the care that they need, and find ways to move care out of expensive hospitals whenever we can. So Oliver Wyman urges an intentional redesign of the state's hospital system. Urgent health system transformation is going to be critical to identifying efficiency gains, lowering costs, reducing inequalities, and improving quality. This can be accomplished largely through creation of regionalized centers of excellence, hospitals that would specialize in certain services so that they can leverage economies of scale and improve quality and reduce costs. If we can ensure sufficient volumes of care, we'll be able to lower the costs of that care and also be able to maintain quality. The report recommends investments in transportation and transformation of EMS systems to improve access to these regional specialty care centers that the report called for. It also calls for increased investment in primary care, mental health, long-term care, and hospital at home programs to try and prevent those costly hospitalizations and shift patients out of hospitals into lower cost, more appropriate, and frankly, more comfortable care settings. It recommends UVM Medical Center lower administrative costs and improve clinical productivity to increase specialty access. And finally, the report predicts that Vermont will need as many as 4,000 more long-term care beds in the next 15 years. And it urges us to start planning for that capacity now. They also recommended a shift in how we address our current challenges. Rather than taking a siloed, hospital-centered and hospital-specific kind of stop the bleeding Band-Aid approach, the Oliver Wyman team suggested a holistic, statewide, intentional redesign of the whole system, looking at an integrated and comprehensive way, recognizing that changes to one hospital must be considered in relationship to the whole. The report offers strategies for AHS, for the legislature, for the Green Mountain Care Board, and each hospital to consider. Again, I would point you to the full 144-page report for details. Interested members can also watch the recorded public presentation of the report by the Oliver Wyman team. This is, my last few slides here are really to convey a sense of urgency. The end goal, I believe, of Act 167 was to create an intentionally designed blueprint for the hospital system we want to have, a system we can afford, and one that meets the criteria set out by Act 167, an efficient, affordable, high quality, and accessible hospital system, one that meets the population's current needs, but also recognizes the future health needs of the population, and ultimately one that is financially sustainable. So I've tried to make, one thing clear today is we cannot wait to do hospital system transformation. The current system is failing to meet our needs, and inaction is an action. If we leave it to market forces, services will be cut, hospitals will close. It is happening already, and the service disruptions are likely to impact our most vulnerable communities. I think we need an emergency plan. What can be done right now to preserve access to essential services? We're going to need a medium run plan. What can be done in a year? And I think then we need a longer term plan. What can we achieve in 3 years? We can't wait longer than that. Here's why we can't wait. Just last month, the University of Vermont Health Network announced the closure of mental health unit at CVMC, closures of a primary care practice in the Mad River Valley, and disruption of a dialysis at multiple locations. There's at least one, but not two FQHCs that are in danger of closure. The question is, how do these service and facility closures align with the optimized system we need? Are these closures consistent with the grander vision? Personally, don't think so. And I don't need anybody here I think everybody here would understand that the uncertainty at the federal level puts even greater pressure on this important work, right? If new leaders in Washington allow the ACA insurance subsidies to sunset at the end of this year, if they cut Medicaid payments, and if they reduce federal grants to hospitals and other providers, closures and service cuts will be imminent. So the runway we have is short, maybe even shorter, frankly, by the potential actions of Congress and the Trump administration. We need a statewide transformation plan now that identifies changes that need to happen in the next 6 months and those that might take a year or 2 or 3 to implement. This is my last slide. It's a recognition that the next 12 to 18 months will be hard. The road to a redesigned hospital system will be bumpy. Status quo bias will create resistance to change. We've already seen it. It will happen, but change is coming our way, whether we like it or not. The financial headwinds are strong, and they're growing stronger by the day. We might soon start to see gale force winds coming from Washington. So my plea is to make a transformation planned, intentional, and with a whole system view, rather than waiting for sudden, shocking, and disruptive impacts on a single community and most likely a vulnerable community. Act 51 designated AHS as the leader of this next stage of work, working in collaboration with the Green Mountain Care Board. AHS has been tasked with taking the Oliver Wyman recommendations, assessing their feasibility, and directing hospital transformation to achieve the goals of 167. that work before them and all of us is going to be hard. There will be resistance. I think how will we know if that hard work was worth it? I think the answer is if we have achieved an intentionally redesigned statewide hospital system that improves productivity, improves efficiency, lowers costs, and improves population health outcomes while increasing equity and access for all Vermonters, then we'll have achieved our goals. So those are the metrics by which we should measure success of any statewide plan. And that is, I think, all I wanted to say. Thank you for taking the time to hear from the board on this topic. It's really important, and the time is now.
Thank you. Thank you. Leslie, did you? I have a question, but it may not be for this minute, but I'll just put it out there. In the Oliver Wyman report on page 12 is the priority policy changes for legislators in 2025. And there's 6 of them. And I wasn't sure if we as a committee with your advice, wanted to review where we stood on each one to see if we're doing what's needed at this moment. So that was my question.
It was my question as well. I was wondering if you could comment on, you talk about short-term, medium-term, long-term. I think it is very clear that we are in a crisis. We need to act short-term. What should we, as the legislature, be doing? What should AHS be doing? Collaboration with Green Mountain Care Board. What should we be doing short-term to stabilize so that we can then get to more long-term solutions?
I think that's a great question. And I think, there's a lot of recommendations in this report. Frankly, I think we need to get really some important people around the table to dissect all of those recommendations that are made. I think that we need to be trying to balance affordability and sustainability. I think we have to be looking immediately short run at hospital prices and ways to potentially bring down those prices, recognizing that that is going to cause some revenue shortfalls in some hospitals. And I think that we need to then work with those hospitals, and AHS needs to do this. And I'm going to defer to AHS for their planning, but working with, looking at a statewide envisioning of where hospital services should be. And then having some regionalized meetings to start to think about how do we allocate services in ways that are going to allow us to reduce costs of delivering that care. But I think, having some plans for ensuring that service line cuts are evaluated when we cut mental health, when we cut primary care, having some oversight over that, I think would be a very short run intervention. Right now, for example, the Green Mountain Care Board does not have any authority to evaluate those short run kind of immediate service line cuts. So that is an example of something that I think requires some oversight and some planning, and some other states do have that. When there's service line changes at hospitals, there's oversight of that. So I think I will defer to my colleagues at AHS about what needs to be done. The things that the Green Mountain Care Board is looking at is we're looking at things like streamlining CON to ensure that our CON process is as streamlined, and working with the legislature to see if there's things in the CON statutes that could be changed that could increase competition and increase entry of other providers. So I think that's I'm looking at the thresholds. I think that's important. We're exploring other ways to evaluate administrative costs at hospitals. We are looking at reducing, I think there was a recommendation about reference-based pricing. I think that's an interesting avenue to explore, is how we actually regulate prices of hospitals. And I think you may hear that it would be difficult for hospitals to survive on, say, 255% of Medicare. I think that's true with the given cost structure of hospitals, but if we could move to a different cost structure of hospitals, and we could then have hospitals be able to operate at closer to Medicare, it would be more affordable for everybody.
Would you, I'm sorry, would you mind just defining reference-based pricing for any of the members that don't?
So reference-based pricing is basically taking the price of a hospital service, particular service, and the assumption is that Medicare pays costs. And so then, 100% of costs are covered by Medicare. That is an assumption that's worth evaluating further. But if we take that assumption, and then it's looking at the multiple of that price that the private insurance payers are paying. So if it costs $100, Medicare reimburses the service at $100, 200% would be that mean that service for privately insured would cost $200. Right now, currently at some of our hospitals, privately insured patients are paying 300%, 400% above what Medicare is reimbursing for those services. So when you do reference-based pricing, you're saying, we're going to set prices at a level with a reference to what the Medicare price is. And so instead of having hospital services be at 350 or 300%, it's like saying, hey, we're gonna move those prices down to 200 or 225% of Medicare. We have standardizing prices across services across hospitals. Yeah, but I want to defer to our colleagues who have done already work on thinking about what the next steps are and what the short run, medium run, and long run solutions are.
Do you have any statistics concerning how well the public understands what's going on?
I don't have statistics. The answer to that is no. I don't know what the statistics are. I think the public understands things that affect them. I think the public understands that they are unable to access care, that they're waiting a long time to get to a specialty provider, that they may not be able to get into a primary care clinic. I think the public understands that. I think the public understands their property tax bill. I think the public understands their cost sharing that they, and their premium growth. So I think the public understands the cost of the care and their access to care has been compromised. I don't think the public fully understands, one, the potential, financial strain on our insurer, our largest insurer. I think that many people think that wrongly that Blue Cross Blue Shield has a ton of reserves. I think they mix the Aetnas and the Humanas and the larger national insurance companies that are for profit and generate lots of surplus with our local Blue Cross Blue Shield of Vermont insurance company, which does not have those reserves and they're nonprofits. So I think there's a disconnect between what people understand about where the money is. There is no more money at Blue Cross Blue Shield, I do not believe, or very little money at Blue Cross Blue Shield. I don't think that people understand fully the financial strain on hospitals or the why. I don't think people fully understand the operating margins of their local hospital. And I don't think people probably fully understand the trajectory that we're facing with the current, potentially with the current administration's plans and where the financial health of our hospitals will be. But I will say, I think the public is very engaged. And I think that's a testament, to these community engagement meetings that happened for the last 18 months. I think people care, they want to be engaged. We attempted to convey this information in these meetings. But I think more information needs to be shared, and to the degree that you all can go back to your constituents and explain the financial strain on our healthcare system, it would be incredibly important.
When you say the public is engaged, do you mean just ordinary people that have nothing to do with?
A lot of public comments. We get a lot of public comments from ordinary people. Certainly, and the Green Mountain Care Board gets weekly, and we read them all. From people who are telling us about their access challenges, people telling us about their cost challenges. And I think in the community meetings, we had people from all walks of life attending those meetings and interested in their hospital and the solvency of their hospital and their access and cost challenges. So I think healthcare is top of mind for a lot of people, but I don't know that everybody has the depth of understanding of the crisis that we're currently facing.
I think that's important. Because that's what I feel too.
Yeah. Yeah.
When I talk to a group of people, they have no idea what I'm talking about until after I tell them. If you say Blue Cross Blue Shield is on the verge of bankruptcy, they look at me like I got two heads. They don't believe you. Oh, it's all those people making all the.
Yeah.
That's what's in their mind.
Yeah. And that's why we have to correct misinformation or just not enough information. It is really important that we do this work.
I have a question, but if anyone else has a question, I'll defer to them. Okay, I will ask my question.
Me.
You know, I mean, we've seen the slide where Vermont is in reference to sort of the national average. And we see it up, up, up. And I mean, I have a million recurring questions that go on in my head, but one of the things that I keep coming back to is we have, in the state of Vermont, we have attempted multiple levels of reform. I mean, not too distant past, we were touted as one of the states that was, you know, driving the conversation on reform. Was there any conjecture at all in the Wyman report on how we got to where we got? And how possibly our previous efforts at reform may have exacerbated some of this unintentionally? You know, I'm looking at the data that I'm seeing around utilization that is coming out just in the, you know, it's gone from 3-alarm to 5-alarm. And I just keep hearing this, you know, the severity and patients are less healthy. We just spent almost 10 years trying to pay for quality, fixed payments for quality. Have we unintentionally done things? And I'm afraid we're going to grasp at something new to try, which is going to lead us even further. And was there any talk about what we've done in the past and how it might have led to the situation we're in right now?
I think there was, I think there was some mild reference to past reforms. I don't think it was a real focus of the Oliver Wyman report. I think that they were looking at the current state of the healthcare system and evaluating the current needs and the current and the future needs of that healthcare system. And to the degree that there was reference to, if you're going to, there was a recommendation that the system would need to be prepared if you were going to move to global budgets. So ensuring system preparedness prior to global budgets was a recommendation in there. A recognition that if global budgets are designed, for example, to move care out of hospitals and into, making sure there's long-term care and mental health and primary care, that you actually have a strong structure there to receive those patients. And so there was some recommendations there that the system needs to be prepared before you move to that different type of payment system. But it wasn't a huge emphasis of a look back at, for example, the all-payer model's impact on our current system. But there was a forward-looking, if you're going to continue down the path of moving from fee-for-service to global budgets, and you're going to move down to a path where you're going to pay, a fixed payment, making sure that we actually, in some sense, have the system is right size, and then you layer on top of that a global payment is a part of it.
Lori?
Seems like everything that's on the table potentially, other than like investment in housing, investment in transportation, but to actually transform the hospital system would be considered a cap. So reference-based pricing, a global budget. And we're already seeing service line cuts. So how do we marry? And is it statute changes we need? Like you talked about, that Equity Care Board doesn't have the capability right now to have oversight over service line cuts. So I'm thinking those types of things. how do we marry this ability to reduce prices or reduce the cost of health insurance in our state, healthcare in our state, at the same time that we're trying to transform without it being service level cuts? Do you know what I'm trying to say?
Yeah, I mean, it's very difficult, and I think and that's why I say the work ahead. I think you can think about payment reform and you can think about delivery reform, right? They're different. And I think the work ahead is delivery system reform. And then you can start to think about what is the payment reform that you might lay on top of that. And when I hear, yes, sometimes system redesign may mean moving of services from one area to another, but it could work in both directions. So you may find some services, like let's take orthopedics. You move some of that services to a specialized, few regionalized orthopedic surgery centers across the state. You're going to ensure, for example, that there's enough volume to ensure quality of those hips and knee replacements that we know that we're seeing. And you can lower the cost of that care. And if you also layer on top of that enough transportation so that people can access that care, that's the type of delivery system reform. It would reduce some costs. It would free up some resources. And maybe there's an opportunity to move in the other direction of more primary care in that area or more long-term care in those areas where you've moved orthopedics out. But let's look at what the primary care needs are in that community. Let's look at the mental health needs in that community. It's really about intentional design to ensure that essential services are delivered in every community, and that where you can regionalize specialized care, you do so in a way and ensuring transportation to those sites that you're able to lower those costs and improve the quality while ensuring access to the investment in transportation. But it's an intentional redesign, I think, of the delivery system that is, yes, in some cases, there may be some services that are going to move to regionalized centers with transportation access. And there's going to be a recognition that there are some areas of the state where there is no nearby, hospital. And those hospitals, I'll take North Country as an example, that hospital up there probably needs an infusion of resources. This is my opinion only, but there is not a lot else up there, right? And so primary care, mental health, long-term care up in the community, they're going to need the resources to be able to support those needs, and transportation to the specialty care that they cannot afford on their own, to hire enough doctors to cover for the size of that population. So it's really about intentional design, recognizing population needs.
Just so that kind of leads back to your question, and it seems like we've spent the last 10 years on payment and not delivery.
Yes.
And so now we need to swap those. And I think Chair Foster, I wasn't here, said yesterday, like pick one, and the picking one is on the payment, but we need the delivery changes too. Sorry.
And that's hard
Well,
work.
mine is expanding on that, which is, what do you do first? Because you have to, it seems as though they have to align together. You cannot remove orthopedics from one place if they're relying on the revenue that orthopedics generates to subsidize the other, without changing the model of how you're paying them at the same time. But so I guess my question is, which comes first?
I think it has to be, I don't think it's fully sequential. I think they do, they're complementary, right? In some cases, you can actually redesign the payment system to incentivize the types of delivery form that you want to see. But I think that we have been very focused, frankly, on payment reform, less focused on delivery reform. And so what I guess what I'm suggesting here, and again, I'm just one person, that we need to prioritize some of that delivery system reform. And I think my point about intentional is that if we start to really think about this, where do we want services? Where is it most effective to have services? How do we ensure that essential services are kept in the communities that need them? If we're intentional about this, right, it's going to lead to a better outcome than if we bury our heads in the sand, frankly, sorry. But if we don't do something about it, these service lines are going to close. We are already seeing that, right? We are already seeing that. And I am deeply worried about what is coming down the pipeline from Washington about resources coming into the communities. If there are Medicaid cuts, if there are these ACA subsidies, if they are sunset at the end of the year, many of our privately insured rely heavily, right? Folks on the individual market and the QHP rely heavily on those subsidies. If those subsidies sunset, then we're going to have an increase in our uninsured rate. And some of those hospitals that rely on the private insured to plug the holes are going to be in greater financial danger. So my point really here is intentional delivery system reform, because unintentional delivery system consequences are coming our way.
Stacey? I am so grateful that you're separating payment reform and delivery system reform, but I want to make sure that everybody understands and we're speaking the same language. How are you defining delivery system? Does that include practice improvement, operational efficiencies? Does
That's
it
all of
include, okay, can you talk a little bit about that? So people understand.
When I think of delivery system, I think about what are the people and the facilities and the resources in place to deliver healthcare to Vermonters. So it's the physical infrastructure and it's the workforce and the equipment together that deliver healthcare, right? So when I think about that and I think about, well, where should we allocate? How should we allocate the delivery of care? Or how should we think about the optimal allocation of those resources of people and equipment in place? That's what I think about as delivery system. So it's more than hospitals, to be sure. It's the DAs, it's the primary care practices, it's, the long-term care beds, it's all of that, right? That's the delivery system in my mind. Does that answer your question?
Thank you.
I have one last question. I'm sorry.
That's okay. It's great.
I'm hoping you can help.
I just
me,
feel like I don't have
actually.
all the answers here, so I'm trying.
I know all of this and this sort of goes to Topper's point. I have a folder in here with 17 letters from towns that say, don't touch my hospital. And the hospitals are coming back with, this is inaccurate and, don't take this away, don't change this. What do I say to those 17 letters?
Yeah.
About why?
Yeah, this is the difficult part, right? It's just like schools, right? Everybody wants in their community, the school, right? Near them that has all the services. Everybody wants in their community a hospital that can offer all the services. I think that's true, that people want that. I think the question is, what can we afford? But I think maybe the way I might frame it is trying to give people a sense of the vision. Where are we going with this? If we do this right, then that they will still be able to access services. Those services will be at lower cost and higher quality. If we have a blueprint for where we need to be, it's a vision. We need to give people the vision of the future. And that vision of the future is a vision that would potentially have higher quality, lower cost care for them. And would allow them not to be making those choices of potentially not being able to pay their rent or having their healthcare or ensuring that they are able to hire people for their businesses, and that their property taxes are not making it so that they cannot afford to live in the state. And I think it's a part of a larger conversation, but if we can give people the vision of how things will be, and it's an optimistic vision, I think that might be helpful.
Oh, Mari, what do you?
I think also a realistic vision with that of doing nothing is devastating.
Absolutely. Yeah. The inaction is action.
I would just like to defend the hospitals briefly. I think a lot of our hospitals, and Devin can talk about this later on, but a number of hospitals are cutting services. They're joining forces with other hospitals to share those services. So many of them are already doing these things and have been doing them even before Act 167. So
No,
I would push back a little bit on what you're saying. And the fact that we are spreading some of those services to other hospitals is going to cost money because you're going to have to hire more people. You're going to have to build more facilities at those other hospitals that are taking on that work. So anyways.
No, I appreciate that. And I don't want to dismiss that the hospitals aren't doing hard. I mean, they are absolutely doing hard work. And they're doing the best they can to care for the patients in their communities. Absolutely. And I don't want, and if I've said anything that, you know, is.
You didn't, but I just.
Yeah, no, I appreciate that. Everybody, I would say everybody is doing the best that they can. I really do honestly, genuinely feel that way. Hospital leaders and our insurance company leaders and our, you know, providers, our primary care providers, our mental, I mean, everybody is doing the best they can. As an economist, I can say, hey, we have scarce resources and those are being allocated and it's constrained and people are working within those constraints. But we're starting to see the fallout from those constraints. And so the question is, could we think about how we might allocate resources better to improve population health outcomes? And I think that's the question.
All right. Thank you.
Thank you.
Thank you for coming in. Just let me get a little consensus from committee. Would you all like to power through till noon, or do you want to take a short? Right. Oh, there's 30 slides for the okay. 30 slides for the next one. Let's power through. And if anyone needs to like take their own personal break, then feel free. Hi, welcome.
Thank you.
Go ahead and introduce yourself.
For the record, my name is Brendan Krause, and I'm the Director of Healthcare Reform at the Agency of Human Services.
Thank you.
All right. Well, thank you, Madam Chair and the members of the committee. I've been asked, as you know, to come to provide an update on both transformation and some mention of payment reform. But I would like to just sort of set the scene that I'm going to talk initially about healthcare reform as an overview, and then specifically about care transformation in response to Act 167. We will discuss ahead at a very high level, just as it relates to Act 167 and transformation, but per the chair's request, we'll be having a more detailed conversation about that in the future. So I will not get into the detail, which is very difficult to do. But, so I'm trying to keep that at a high level. I'd also like to acknowledge that we're not going to go into depth on issues like health information technology and health information exchange and workforce, which are all very essential to reform, but really warrant deeper discussion. So starting off with the healthcare reform overview, we are very much aligned with our colleagues at the Green Mountain Care Board about what needs to happen and totally agree that the vision is the place to start, though we do have immediate needs that we need to address. So our vision for health reform is that Vermonters will have the right care at the right time, at the right place, at a price they can afford. So easy. So the context for reform, I'm going to repeat some of the issues that have been raised, but it's worth it because they're very important. Vermont's healthcare system is facing challenges in affordability, sustainability, access, and equity. Health insurance premiums and out-of-pocket maximums have risen dramatically over the last 5 to 10 years, and specifically over the last 4. Vermont's health insurers are facing financial stability issues. Vermonters are experiencing long wait times, so we're not just paying more, we're not getting what we need. Gaps in community-based care results in increased hospital use, and low-income populations, particularly in rural areas, are facing health-related social barriers, needs which may create barriers to them receiving care. Specifically, 14% of Vermonters spend more than half of their income on housing. 14% of Vermonters lack access to broadband, and 9% of Vermonters are food insecure. Simultaneously, Vermont's population is aging while the working age population decline. So how do we begin to bridge the gap between this vision and the reality? I'd like to start off by sort of sharing our vision for healthcare reform goals and tactics. So what is it that we want? We want affordable care that's accessible, that's of high quality, that is equitable, and that meets the needs of both patients and providers. And as Member Holmes discussed, care and delivery transformation and payment reform are distinct, but they're very much related. And so we're going to I'll be talking about each of those in turn. And then so when we say care delivery transformation, as Member Holmes said, we think about the people, the tools, the resources, the places, the way that care is delivered. Payment reform, we think about are we adequately paying for the things that we want? And are we paying in a way that enables those things to be delivered? And are we giving providers and people in the system the right information at the right time? And that's sort of about the data and information technology. All of this needs to occur where we are considering health-related social needs and determinants of health, and of course, legislation and regulation. And just as an example of what I'm talking about in terms of state experience with delivery and payment reform merging, you can think of the Blueprint for Health or the Vermont Chronic Care Initiative as models where we've just changed the way that we deliver care, but also pay for care to meet particular needs. So how does this relate specifically to care transformation and Act 167? Healthcare transformation is critical because of the financial fragility facing the Vermont health system and the access and quality issues that result. We believe that over the next immediately and over the next 3 to 5 years, Vermont is looking at a significant transformation agenda. Now is the time to begin, but we also need to plan strategically and make sure that we're setting ourselves up for not just emergency fixes, but long-term sustainability. What does healthcare transformation aim to do? We aim to improve affordability by reducing growth in healthcare costs, to increase access to essential services, to improve health and quality and experience of care, and to improve outcomes for individuals and all Vermonters, including reducing inequalities for populations. Successful transformation also relies on effective support for healthcare providers, and I'd like to acknowledge that not all providers are in the same place or have the same resources, and some will require more operational and analytic support than others. So Act 167 specifically tasked the AHS and the Green Mountain Care Board to collaborate on a new alternative payment model, directed GMCB in collaboration with AHS to conduct stakeholder engagement and to report on hospital transformation, and then directed AHS to lead care transformation activities following the completion of that analysis and engagement. Act 167 set a path for reform, and the work links to the broader AHS reform initiatives. I'm going to briefly touch on the all-payer model that has been mentioned in passing. The first task to the board and to the agency was to consider an alternative payment model and delivery system approaches for hospital services and community-based providers, such as primary care providers, mental health providers, substance use disorder treatment providers, skilled nursing facilities, home health agencies, and providers of long-term services. What did we find? When analyzing federal models, we found that no one model accomplished all of the goals laid out in 167, and therefore pairing models would be required to address the goals. Federal models that could most easily be paired to most closely match the requirements set out in Act 167 were the all-payer health equity approaches and development model, or AHEAD, and CCBHC, known in Vermont as Certified Community-Based Integrated Health Care Centers, which are mental health and substance use providers. I'd also like to acknowledge that all of these models contain inherent risk. These risks include resources to implement the models. So whether or not the state, as most mentioned, is well-positioned and well-resourced to do a good job at implementation. The impacts on commercial rates and affordability, impact on access and quality of services. So will these models result in stinting of care? And sustainability of healthcare providers. So will these models enable providers sufficient resource to meet the needs of the population? So why was AHEAD selected? When matched against the criteria of Act 167, we found that the AHEAD model addressed total cost of care targets, included multi-payer hospital global budgets, set specific targets, strategies, and investments for primary care, and opportunities in the broader continuum of care with targets to be identified by the state in mental health and substance use, home health and skilled nursing, and specialty providers. It includes strategies and investments to address health inequalities and the social determinants of health. And it clarified whether or not the state needed an ACO, which it does not involve ACO. So just as a status update, the next steps on the AHEAD model, the board and the agency have been negotiating with CMS since July of 2024 when the model was approved, when the application was approved. On Friday, 17th of January, all parties who are signatories to the agreement signed, including the governor, the secretary of the Agency of Human Services, the chair of the Green Mountain Care Board, and CMS. The executed state agreement commits Vermont to participate in cohort 2 of the model, which would begin January 1st, 2027. But as mentioned, we're not here to get into depth on the AHEAD model. I think it's important to establish the current state and how it relates to Act 167.
Leslie, did you?
I have a question about the implementation of AHEAD, and I understand you're not going deep, but just to get it out there, there's a gap year, particularly for primary care.
Yes.
And, member homes really talk about the emergency.
Yes.
Primary care, we're having an emergency. We've had 2 closures with different payment models. So I'm wondering how you in your department, AHS, are thinking about this short-term emergency.
Yep.
And how you're going to deal with that gap year.
We've been very focused on the gap year and the gap it creates financially, specifically since the beginning of the negotiations. You'll have seen in the governor's budget request that there is some money specifically for primary care, basically the Medicare funds that we will lose in this gap year to support things like the Blueprint for Health and support and services at home or SASH. And so we can go into more detail with you on that. There are regulatory partners at the board are also looking to see what they can do in order to help bridge the gap. But to be fair, it also speaks to the issue of becoming well prepared for the model. And so the downside is that we have this significant gap year, and I guess the upside is that we have more time to prepare.
If I may,
And then we'll go to Woody.
I'm still thinking about primary care. Is there conversations happening anywhere about supporting communities who have lost primary care in this recent past? Because there's this issue. I understand about the consolidation that needs to happen with some of, particularly North Star or whatever.
Yep.
But where is that work happening?
Yep.
I understand consolidation. I don't understand being abandoned.
Yep.
And I'm having trouble with that.
There's and most of the work right now in provider sustainability, especially addressing the FQHCs and other primary care models, is happening at the Department of Vermont Health Access, and we can provide. It's actually happening as we speak. So, and you'll also have seen some emergency sustainability.
Well, the $10 million, but I don't understand how that will affect my community. I probably don't have an answer, but
Yeah.
I'd like to at least somehow
absolutely.
get to an answer.
Yeah, I don't have the answer, but I would
Yeah.
love to discuss.
Yeah.
So
Thank you.
it's
Woody, did you?
Yes. The AHEAD model, I understand that this is probably for the Green Mountain Care Board. You have 3 to 5 individuals that you're hiring to help with the AHEAD model. What exactly are these personnel going to be doing? And I know we can't get into specifics, but
they're actually not for the Agency of Human Services, so I would defer to the board about how those resources would be used.
and we've spoken about this. Our hospital's going to be mandated to join.
There is no plan to mandate hospital participation. We are mandated by the agreement to reach particular participation rates. So in terms of Medicare spending in statewide, but it does not mean that all hospitals have to participate.
Okay. And it seems like we're going from one model to the other. Is this going to be helping our transformation into a new system?
We have slides about that. So yes, the theory is that if the investments are realized, which that we predicted through this, we'll get into the detail of it. But anyway, long story short, I think it's important to say 2 things about that. This model that we're currently in will end at the end of this year, no matter what. Like the CMS is no longer approving state-specific models. Originally, the intention was to go from one to the other to protect the primary care resources that were flowing into the state. and to provide stability to hospitals so that they know, basically the rules that they're playing by, I suppose, for the next 9 years, rather than having a period of instability or uncertainty. And so that was the original reason. And because it aligned based on the slide a couple of slides ago, it aligned with the transformation agenda. So in other words, it allows the state the flexibility to redirect some Medicare payments that otherwise would be in the fee-for-service model to primary care, to substance use treatment, to long-term care, to those other delivery system infrastructure, for lack of a better description, that is lacking in the state. So that was the intention, is the intention. Okay, so getting specifically, so again, I'd like to thank my colleagues at the Green Mountain Care Board for the work that they've done on stakeholder engagement. We're continuing to learn from them, both in the data they presented, but also in the process as we move into the next phase of transformation, which was directed to AHS in order to reduce inefficiencies in the system, lower costs, improve health outcomes, reduce health inequalities, and increase access to essential services. So how are we approaching this? The goal is to facilitate hospital transformation plans to improve access, financial sustainability, and to strengthen primary and community-based care. There's an obvious tension between the need to act now and the need to set a strategy and a vision to bring everyone along and to make sure that we know where we're going to end up. And so our approach to that is to establish a care transformation steering committee, which is consisted of staff both at the agency and at the Green Mountain Care Board, to begin the process of setting that vision at a statewide level. However, it is also important to start moving. And so in terms of state's transformation activities, we are working with hospital and health system transformation planning and implementation, including quality measurement and health equity framework development, creating statewide dashboards to monitor impact of health reform in real time, continued payment model negotiation with payers, and continuation of enhancement of provider stabilization and long-term sustainability efforts. And importantly, we will build on the delivery system infrastructures of the past 10 or more years, including the Blueprint for Health, Vermont Chronic Care Initiative, field service workers, and health information exchange. So specifically, healthcare transformation plans and technical assistance for hospitals and primary care entities are being provided, including FQHCs and district DAs. And getting to your point, Representative, the equity access and statewide transformation fund under the AHEAD model, which is where those flexible funding streams will lie, will provide Medicare support for transformation initiatives. So I'd also like to acknowledge that transformation is already happening. Since Act 167 was released, healthcare stakeholders across Vermont have already made notable changes. I think it's also to recognize that some of those are good and some of those are negative. I'd also like to reiterate that transformation is an iterative process without a defined endpoint. And over time, AHS's transformation efforts will serve to elevate the state's healthcare reform vision and provide much needed stability. But and again, to begin supporting hospitals in their transformation efforts now. So how are we doing this? So while yes, we have the important work of a steering committee and vision and bringing stakeholders along, there's also just the nitty gritty work of getting down to the analysis of feasibility and impact of many of the recommendations in the Oliver Wyman report. AHS is contracted with the vendor, the Rural Health Redesign Center, who has experience in rural hospital turnaround to support transformation planning at Vermont's hospital and primary care practices, FQHCs, and DAs. The goal is to optimize Vermont's response to recommendations from the community engagement work and to support the implementation of the AHEAD model as appropriate. So to recap, the Oliver Wyman report provided a lot of options and recommendations for consideration, but we are now assessing the feasibility and impact of those to see which make the most sense for which communities. We're also preparing for the AHEAD model and assessing how these initiatives would work together and balancing the needs of each community, region, as well as statewide recommendations. Specifically, sorry.
I think Leslie has a question.
Okay, I'm sorry.
Well,
I'm
you
not good at
mentioned
moving glasses.
designated agencies, and you may not need to go here now, but we had a slide a couple of days ago about their payments, and it was horrible compared to hospital payments. So when you talk about designated agency redesign, how do you take that into account in order to split them from each?
Yeah, I don't have an answer for you now, but it's high on the
I
list.
just wanted to get that. I just,
Yeah,
like,
thank
looking
you.
at that slide was like scary.
Yeah, no, I mean, yes, those both, that's why we've elevated FQHCs and NDAs to the sort of front burner, if you will, of transformation.
And that would be great to hear about what that means to be front burner.
So specifically, this technical assistance is about implementation. So we will be engaging with hospitals again on the feasibility, impacts, and operational considerations of participating in addressing transformation activities. We'll track quality and financial data over time, reduce health inequality, measure the reduction of health inequalities, and study demographic and health-related social needs data and collect that data. We will be developing we are starting to develop transformation plans in the short, medium, and long term. So what does this mean? What's happening? Currently, information sessions to engage providers are beginning. We are then launching our technical assistance program with individual hospitals, both on-site and virtually. We will then begin developing in Q3 that technical assistance will feed into developing short-term hospital transformation plans, mid-term and long-term. And then we will continue to rinse and repeat until the job is done. We will also be implementing a hospital peer-to-peer learning collaborative so that hospitals can dig into specific policy solutions in specific domains and scale those solutions or share those learnings much more rapidly. So how does AHEAD relate to the transformation agenda? The AHEAD state agreement includes an equity, access, and statewide transformation fund, or EAST fund, which would be funded through flexible Medicare funding secured via the negotiation with CMS. The funding can be used to stabilize healthcare providers, to address access issues, and increase availability of services in the continuum of care, specifically in areas such as mental health and substance use disorder, primary care, including FQHC, home health, long-term care, and specialty care initiatives. Just to give you a sense of this estimate of the fund, in year one, had we begun in 2026, we were looking at about $140 million added to the baseline of our Vermont's Medicare spend. We don't yet have numbers for what that will mean in 2027, but it's likely to be more, both because of the trend that will increase over that year, and also because early evidence shows that Medicare Advantage take-up rates are lower than they were.
I know that you had a question a couple slides ago. Did you want to ask that? No?
If you want me to.
Yeah, sure.
On page 17.
Sure.
Go down to understanding and moving towards capitated payment models. Can you tell me how that translates into the delivery of services to individuals?
I can at a very high level. This is also part of the assessment of whether, what impacts the AHEAD model or global budgeting would have on individual institutions or communities. The idea is to, sort of getting back to the earlier conversation about cost growth, to incentivize to provide the flexibility to deliver services that aren't based on a fee schedule, aren't based on fee for service, at the same time as creating predictability in cost growth. And so it's very much about helping organizations to understand what a capitated model would look like for them. And I don't know if anybody else has anything to add in that regard, but if that makes sense.
Yeah.
So the idea is instead of,
Okay, let me tell you what I hear.
okay,
I hear less service being provided. Am I wrong?
that is certainly not the
I know it's not the
the
intent.
intent, but, and it would it would require extensive quality measurement and access measurement to make sure that that wasn't happening. And it gets back to the concern about any stinting of care that goes with any model that tries to cap or control growth.
Leslie, did you want to?
I want to expand on Representative Sean, because I think it's an important point. And how do you measure stenting? How do you measure care that's not given?
It's a great question, and there are smarter people in this room than me on this. There aren't very good access measures. Part of the transformation work that we are engaging in involves measurement development that we'll be doing in concert with our colleagues at the board. One of those is about access. Others are about health equity and other quality measures to get at that. And I should be very clear. The point in the slide is that we're going to support the analysis with communities about these models, not tell them that they have to use them. So it's about understanding whether or not the benefit outweighs the risk.
So we don't know. That's the point.
Yeah, we don't, but
Yeah.
but it's very much on the roadmap. And we're working
Is
with
it
a vendor
early?
right now.
Did you have a question? I'll let go. I'm sorry.
I thought we'd wait. I'll wait
Okay.
till the end.
Okay, great. Let's go on.
Right. I'm getting there.
Save your questions, everybody. Well,
Yeah, that's better for you. All right, so we did ahead. Actually, this is my last two slides, so we're good. So I just also like to acknowledge broader work that's happening at the agency and beyond. So transformation obviously is not just about Act 167, and we've seen some early progress. So in mental health, the 988 suicide hotline, mobile crisis, mental health urgent care, skilled nursing facility, rate increases and changes in methodology, substance use disorder rate increases to residential programs to support co-occurring treatment at hubs. Some financial support to home health by sunsetting the provider tax. Some hospital post-pandemic stabilization added through the Medicaid DSH program or disproportionate share hospital program. And recent blueprint expansion, including universal screening for health-related social needs, mental health and substance use disorder, embedding mental health into the primary care setting. So we've seen some early success, fewer borders in ER and inpatient, flattening of the curve and early signs of reduction in deaths from suicide and overdose, but we have a very long way to go. Health and Human Services organizations are facing extreme sustainability challenges. Insurers are facing financial instability. Vermonters' costs are increasing at a way that is not sustainable. While what we are seeing is often the result of demographic challenges, we still must act now. The system we have now is not going to work going forward, and so we must create one that does.
Could you discuss the dish payments?
I would have to. I probably am not the right person to do that, but I'm happy to take your questions back and get back to you. It's very complicated, and I will get over my skis very fast.
I know others have a question. I had a really quick question before. One of the immediate responses or immediate steps that the Wyman report indicated was strengthening emergency medical services, EMS services. And I'm wondering if because I do know that I remember from last year, if I recall that there was work being done around the payment methodology. And additionally with Medicaid transport. And I'm wondering, has that taken place yet? Or
Yes, and
what's going on with that?
fair enough, and I'll come back to you on that one as well. And the reason is that work is happening out of the Department of Health and also the Department of Vermont Health Access. But having said that, transportation in particular is definitely going. We will use it as one of our learning collaboratives. I think that it's I think it's an issue that will have different solutions regionally, but is absolutely something that requires a statewide lens and may well require statewide resource.
Is it being
to address.
prioritized?
I'm sorry.
Is it being prioritized?
Oh, yes, absolutely. Absolutely. Yes.
Okay.
Short answer. I mean, I think that transportation and other health-related social needs, but transportation in particular is a potentially low-cost, very high-value service that could dramatically improve access to healthcare and efficiency, frankly.
I've seen a couple hands up and
All
they've
into the
all been
queue.
all in order. I'm going to start with Mari and then Lori.
Hi, thank you for coming today.
Thank you for having
Mine
me.
is more of a request. Independent physical therapists in independent practice are really struggling, much as dentists have with Medicaid rates, and are asking for Medicaid reform. It's becoming more, they provide critical services in the community, and it's becoming much more difficult for them to be able to continue to see Medicaid patients because of the payment rates. So if you could take that back to AHS, more specifically to Diva, my request that in this work that you include the independent physical therapists.
Thank you.
Yeah, thank you.
Lori? So I have a couple questions.
I saw you right.
Yeah. Yes. So thank you for coming. And you didn't say this, but I think you've only been on the job for 6 months or so.
thank you.
So
Yes.
appreciate, the hard work that you have ahead of you and learning our system here in Vermont at the same time. Is hospital transformation a voluntary process?
We don't have the ability to compel transformation, but we haven't approached it like that. And we so far don't feel like we need to, because there's been such positive response, frankly, from the hospitals and their colleagues at VAS. They've been very supportive and reaching out to us, and also, helping us vet our ideas for transformation and how workable they are, frankly, and if they're going to meet the need. And so I don't think that's going to be required. I'm very optimistic that, by providing the resources that the hospitals need, as Member Holmes was saying, they're working hard every day, and some of them just don't have the resource
Right.
to take a step back and say, wait a second. And
Like,
that's what we're
it's
trying
kind
to
of like
provide.
municipalities when we provide technical resources for
Yeah.
work, but I guess and I understand the hospitals are being supportive. I guess my concern and understanding it's, you don't have the capability to make it mandatory. How do you then assure it truly is system-wide, right? So we can't just have 4 hospitals
Right.
doing it
No.
and not the other 10.
Right. And I think that means a collaborative approach, both across our agencies and with our stakeholders, but also with our regulatory partners at the board, and legislators, quite frankly. So, I think that's something we need to keep our eye on.
Okay.
I hear you about the statewide. It needs to be a statewide vision, but we also have to act locally fast.
Yeah.
So I think we watch and see, and I think we just keep a lookout on that.
Okay.
Okay, 2 more.
2 more. How are you measuring success? Have you laid out the metrics yet?
We have. We are. There will be a couple of ways that we do that. That's very much about the work that we're engaging in. Part of where we have a couple of contractors that we're working with who specialize in measurement development and are helping us to do that. But we also will be working with our steering committee, with our internal partners, as we establish that vision to come up with specific measures. So, and then we will have reporting. I think I mentioned a dashboard, that the purpose of that will be to apply those measures and report out on the measures. So not just so that we can share progress, but so that we know what's working and what's not in terms of transformation activity.
And sorry, now I have 2. And so when do you think that you would have those measurements that you could share with us? What's the timeline on that?
I'll have to get back to you on that. We have just scoped the work plan at that level of specificity. So sooner rather than later is our goal. But I can give you an exact timeline. I know that, my timeline was pretty high level, but we plan that'll get more and more and more specific, and happy to share that.
And then lastly, member Jessica Holmes talked about the difference between payment system reform and delivery system reform. Do you feel that you have the resources to do both at the same time? And how are you integrating them in this transformation process?
We are Thank you. The Act 167 actually did a pretty good job of laying out a framework for that in terms of the, look for payment models that meet our goals. These are the goals. And then drive a transformation approach that was analyzed through the meetings and the engagement with all our work. So the short answer is a lot of it will depend on whether or not we move forward with the federal ahead model. And in that is very much about creating a payment model that is intended to address the total cost of care, but also bring in additional Medicare resources to provide resources to hospitals so that they can do the right thing in terms of their communities without stinting care. And so that is obviously a bit of there's a bit of federal uncertainty right now. But I think, well, yes, you approach them differently because there is the people, the processes, the place, the resources, the tech. You're not going to get the things you want if you don't pay for them in the right way.
Right.
And so I think that it's separate, but together.
And so then my question is, so how do you have the resources to do both? So understanding we're not till cohort 2 on ahead and anything could happen with that. There is a lot of work that has to be done to be ready, and you're doing this transformation.
Yeah.
So how do you do both?
I expect that we will learn very early what those resources needs are and how we're going to get those needs. So, for example, I would have thought by Q3 of this year, we'll have much more certainty about, federal model negotiations and where they're going. And we will have technical assistance, enough of a vision of technical assistance needs based on the 6 months of work that we'll be able to answer that question.
Okay.
But thank you for the question because
Thank you.
Hold on, top
it's on my mind a lot.
I gotta keep going. I think I was Leslie,
Woody,
Woody,
me,
Daisy, Topper, and then me. I'm gonna put myself in the queue. Leslie?
All right, I'm just writing down the last question.
I wanted you to finish your
Thank
thought,
you.
because that's hard. So your slide on 26 of your deck shows, once again, page 12 of the Oliver Wyman report. And it does have a list of recommendations to the legislature. And I'm wondering if you are thinking about recommending any legislation from us in order to deal with that. Particularly, we know we have freestanding birth center bill, rural emergency hospital number 5, and how you're looking at the other things that you need from us.
It's a great question, and part of our analysis over the next several months and longer will be looking at, what authority currently exists within either our or our sister agencies, and what is needed. So I don't have an answer for you now, but it's one of the will be one of the important outputs, I think, of the exercise of understanding what needs to happen.
Yeah, thank you. I just want to wonder if, there's a lot moving parts and I hear you and you're planning and that's great. Is there a time when we should have you back? Like put it on the calendar, a month, 2 months, some time that we know, then we can get caught up.
When do you feel would
I
be
don't-
the appropriate time?
Maybe I can come back to you on that and let you know. Because it wouldn't just be my decision, I think. So it would be good to talk to others and understand sort of what their timeline is.
Woody?
Yeah, I have a couple of questions.
Okay.
Director, we've met a couple of times and I'm confident in your abilities to do this work. And we all know here how important it is to get this right. And going back to slide 16, where we talked about the rural health redesign center. How was this center selected? How many other companies or organizations did you look at before you chose this one? And do they have experience in what we're trying to do? What other states, I know I'm going on, but how many other states have attempted to do what we're doing? And is this center an organization that has assisted those states, and how successful were they?
The short answer, and we can go back to you with very specific written responses to your question there, in terms of numbers of states and what they've done and how they were selected. We issued a public request for proposals, RFP. We held a bid review committee made up of members from the hospital, from the Green Mountain Care Board, and from the agency sectors. And they were the highest scoring bidder of that committee. And in terms of, have they done this before? Yes. Which states, they're most known for their work in Pennsylvania. But
Where they're located.
yeah, many of them are former state officials. So, but we can get you sort of the breakdown of their customers and
And how many other organizations who get this?
there were 4 bidders.
And I emphasize how important this work is, and I do believe that you're the right person to do
It's
that.
very kind of to say.
But let's be honest, you've got heavy weight on your shoulders.
Yes, I have a lot of partners.
Yes.
That's a nice segue into my question, which is about the support and resources that you have in order to carry out this work at AHS. And are all the positions fully staffed right now?
We have one more. It depends on what happens with the head model. We might, it's possible we'll have some more program heads, or staff members. We have one transformation director position who will be tasked with, really running the day-to-day of this over the next year, 2, 3 years, however long it takes. That we're interviewing that now.
And are there any other hurdles you see operationally to getting this work done?
Not in the short term. We're ready to go. So, and we've started. So I think, keeping an eye on engagement is obviously the most important component, and making sure that we're meeting the needs of the hospitals and their communities. But we feel like we're in a good place. Certain uncertainty, I guess, is the biggest hurdle, but none of us are in control of that, I think, at this point. Political uncertainty, that's what I mean.
Yes. In that discussion but first of all, thanks for coming in.
Thanks for having
I
me.
learned a lot from you. In the discussion about service delivery and payment reform, I want to make sure that I heard you right. Did you say that if we continue with a head model, when you were talking about that doing the both together?
Mhm.
I thought I heard you say if we continue with the head model.
And I guess I say if, because of the federal uncertainty, we don't know what will happen at the federal level. And I know that the board has some concerns as well in terms of some of their statements in their
So
motion.
are you saying that if things change on the federal level, that we can't do this?
It's possible. That's one of the reasons that we signed the agreement when we did, because we knew that there was likely to be a period of silence, if you will, as the new administration reassessed its position on various issues. So
Seems like we're spending a lot of money, a lot of time on a particular model. And to 2 or 3 years down the road, say, see you later.
I mean, I will say the workload currently and regarding the model is not at all what it was even a month ago. So we're very much focused on transformation now. That's where almost all of our attention is focused. Other parts of the state will have work to do in terms of setting global budget methodologies, et cetera. But our team is very focused on transformation.
I'm the kind of person that if I get to a point where decisions is made to do something,
Yeah.
then it's hell bent for leather to
We are
get
in
done.
100%.
And the problem we're trying to solve is real. It's right now. And I'm worried about hospitals, as an example,
Mhm.
going out of business.
Mhm.
Well, we're trying to figure out what the hell we're gonna do.
Which is why which is why I think Act 167 set the task that it did, which was to look for a global payment model or that could help support the transformation activities.
Yeah.
We agree with you. We think it's the right approach and it matches up nicely with those needs. So that was our rationale for continuing. In terms of the flexibility and the investment that we get from Medicare, that is significantly more than it is now.
I'm gonna ask my question, then I think we're gonna end. In 3 weeks of me sitting in this chair, I have heard from our FQHCs who are in dire condition. I've heard from provider groups that have 1 to 2 days cash on hand. I have heard from our hospital systems who, again, their days cash on hand every day is lower and lower. I have heard from insurers who are, I've heard insolvency, bankruptcy. I've heard of almost every single organization that represents the care in our healthcare system. $50 million in the BAA to stabilize skilled nursing facilities. $10 million in the BAA for emergency stabilization grants. I've heard crisis, 5-alarm, unsustainable, front burner. I am deeply, deeply concerned that there is not a sense of urgency. And I am deeply concerned that by the time we start putting things in place, there will be nothing left to transform. What are we doing urgently?
I absolutely feel a sense of urgency. And so what we're doing urgently is, in addition to what you just described, Madam Chair, we're already talking to hospitals about transformation where yes, we brought in this consultant that's going to help us, do things more robustly. But we've been talking to hospitals, all along, and we'll continue to do so. And we have seen some negative, but some positive change. And so we will continue to push on those.
Just hope we're making plans for short term,
Yes, absolutely.
rather than looking forward to the
100%.
medium and the long. Not that those are not important.
Absolutely. And we're very
But we may never get to the medium long. We can't save it in the short term.
100. We're completely aligned with you on that. And that's exactly where we're starting.
Okay. I think we're gonna end for the day. Or not the day, but
I know.
yeah, I think we're gonna end for the morning. So we'll see everyone back here at 1, and thank you so much for coming in.
Thank you for having me.
And well, recognizing you are new in your job.